So again, we should be clear to our audience. So with atrial fibrillation, what's the current standard of care in terms of antithrombotic therapy?
Right. I mean, typically, unless they've had a first it's determining if they need aspirin or not, and then we use something called the CHADS-2 or CHADS-2 VAS score to help determine if we're going to be placing them on either vitamin K or non-vitamin K antagonist. And then now there's some data on when we put stents in these type of patients, there's some strategies with apixaban and rivaroxaban for utilization of antiplatelet and antithrombotic. But I think as we keep saying that, and doxaban, right, which is not much used in our clinical practice. I think all your points are absolutely correct of that. For primary care, they're not going to know the procedural angiographic characteristics. There's going to be a lot more patient-related, and that there should be comfort level in saying that, hey, we're seeing this patient, and that we don't necessarily need to have all these pieces of information, especially 3 to 5 years out, because the stent-related outcomes are dropping. You're 1,000% correct. I think in the endovascular interventional community, I'm trying to make it more aware so that this communication gap
we have to be better.
could be made quicker when we're just assessing that patient and quickly are able to at least say, hey, based on the information we have available to us today, this is the plan that we want to set in place. And I think when I'm seeing all these patients, it helps me, and I quickly look, oh yeah, I wanted to use it for this strategy. Lastly, I think something that, back to your pillars, is that the non-pharmacological therapy is also important. So, for example, there's a lot of data on if a patient eats 3 servings of vegetables and fruits, there's an 18% reduction in MACE on 20,000 patient population study. So simple interventions in diet and exercise as well are very important, and I think in conjunction what we're talking about can help reduce the risk.
Yeah, no, that's an important point. Lifestyle, we often don't emphasize it enough, but
I'll just say one thing. I agree with the notes. I think one thing that you highlighted about atrial fibrillation that I just want to make sure our audience is clear about, right? If atrial fibrillation is present, and you're going to anticoagulate the patient, so first you should decide if you're going to anticoagulate the patient, and I think these days with CHADS VAS score, you would say 2 or greater, most people are going to get anticoagulated.
Yeah.
The next thing you should do is say, do I need an antiplatelet?
Right.
So now we have, I think, now randomized data and other data observationally, but now randomized data that would say, if they haven't had an MI recently, and when I mean recently, I mean if they haven't had an MI in the last year, certainly if they haven't had an MI in the last 2 years, there's no reason they have to be on that aspirin, and you're going to reduce their bleeding risk. So that's number one. Number two is, in your mind as a primary care physician or a cardiologist or anyone, you should have a hierarchy of what am I treating. So patient with AFib and coronary stents and MI, I'm still treating the AFib. Patient with PAD, CAD, recent MI, I'm treating atherosclerosis, and what's the time frame? Patient with no known coronary disease or maybe say atherosclerosis risk, I'm preventing, maybe there's a risk continuum. So I think one of the first steps is, again, just to remember for our pillars, but also our antiplatelet, antithrombotic therapy, what are we treating? VTE. They have a VTE event. Okay, I'm treating the VTE, I'm preventing the VTE. Now I'm done with that episode, I'm going back to preventing cardiovascular disease. So it's just important with all these really opportunities to think about our pyramid of therapy.
Well, it's opportunities for enhancing care or medical errors. That is, the dosing of a lot of these agents, the anticoagulants would vary, because with atrial fibrillation, we're talking about full dose anticoagulation.